So now how do we advise a patient who's sitting in front of you knowing all of this? So the one thing that's also interesting in the research is there is even a question, is it actually the weight loss that matters? Because in medical terms, we notice that most of the cardiovascular risk benefit that somebody gets is in the first 5 or 10 kilogram they lose. So we do not want to try and target people to get to a normal BMI. It's firstly absolutely impossible, but also there's no reason to assume that a normal BMI is actually what is needed for them for their risk to reduce. So you only want to give a target for the first 5 or 10%, but there has been some thoughts, is it because you now have simply less fat on board, or is it because of the amazing dietary changes that you've made that actually cause you to lose weight, that's actually reducing your blood pressure, etc.? And we don't know. So let's just take for a moment and look at the ideal world before we look at our setting, and say you've got somebody who's got some resources, right? So they've got some access to the website, and Wi-Fi's, they can go and read up on stuff. And then you can have quite a big discussion for somebody to be able to understand how they need to feed work. A lot of people do this when they look, for example, at intermittent fasting, which is just techniques of controlling how much you eat when. But very important, quite often there's a lot of emphasis on you have to have a will to lose weight, setting goals. And it's very important to understand that willpower in itself needs a very healthy person with a high capacity, with enough time and support to 24 hours a day counter their need to feed. So simply telling somebody they should just suck it up and not ignore the hunger is actually not applicable for most of our patients. There are some practical advice you can need. And what we want to try and do is help people maximize the natural release of GLP-1 and other hormones. So very simple. We want to make sure that whatever food you eat is going to reach your lower gut, because then you will be less hungry and less of a need to eat. So the thing and the magic substance is actually fiber, not only because it reaches the lower gut, but it also gets digested and creates a host of other amazing, like the short fatty acids, that has amazing health benefits, a lot of which is not even properly advised. In the ideal world, we're supposed to eat more than 35 grams of fiber a day. In the average modern world, we all eat between 12 and 15 grams a day if we are lucky. So the modern diet is not built towards that very easily. Protein, and you obviously want to have protein that is low in fats in terms of calories, and you want to focus on white meat and legumes, and you want to avoid your nitrates. They've got their own problems. There is the concept of resistant starch, which is interesting, and I only came across this recently from the dietitians. So certain white carbs like your maize, your rice, your pasta and potatoes, if you cook it and then you cool it down, so it sits in the fridge for a day before you make your potato salad or whatever, it actually becomes stodgy. And when you reheat it to eat, it actually is more difficult for the gut to break down. It's very sticky. So quite a lot of it does actually reach the lower gut. It doesn't have any of the other health benefits that fiber, for example, has, but it might keep you full a little bit later, and is a trick that you can use for patients who can't afford some of the fancier fiber products. So if we think about diets, in the world of diets, there are 3 main groups that we can think of. Diets we know work. So on the one extreme, on the left-hand side, is the plant-based diet. These are people who are really hardcore. They don't eat any animal products or any processed products either. It all has to be whole food. And you can see why this will work. You are having food that is basically predominantly fiber products, and it's going to be very good at controlling your need to feed. On the other side, which has become a big fad in the modern, especially in the West, the sort of the higher socioeconomic areas, is the high protein diet has become very, very popular. You can see why the high protein diet would work. So the high protein diet, low carbs, means again that most of that food's going to lead to the lower gut and should make you less hungry. So if you eat less while you're on a high protein diet, you will probably lose weight. The keto diet, which is an extreme of that, where you don't have any carbs at all, we don't actually have any research on the long-term effects of it. And what tends to quite often happen with a high carb diet, the high protein diets, it's quite easy and nice to eat lots of meat, and people don't really keep up the vegetable levels to the same level. So they might not get in the fiber and the other minerals and vitamins that are important. So you can do a healthy high protein diet and you can lose weight with it, but it certainly takes quite a bit of resources and quite a bit of knowledge. The middle of the road diet, which has actually been also got the most evidence in terms of sustainability. So this is the one diet that shows it does help people to lose weight and is most likely to be sustained over a long period of time, is the classic Mediterranean diet. And we now understand the Mediterranean diet. So basically your vegetables and, very important, whole grain starches forms the bulk of your diet. If you're following a so-called Mediterranean diet, so you're adding a little bit of fish and a little bit of chicken and some nice veggies and some starch, but all your starch is white pasta or white rice, then you're not following the Mediterranean diet and you're not getting the benefit for that. So the trick with the Mediterranean diet is the whole grain products. And the question you need to ask any patient if you're going to try and get them to go on some fancy diet is, can they eat like this for the next 20 years? Because if you can do a massive effort for a year, get your weight down, go back to the way you used to eat, and all of that years would be completely wasted. I'll have a quick word on medication just because it is very current. So Ozempic, the drug that is all over the news and that the celebrities love so much, is when they discovered, after actually doing when they do this, the barometric surgeries, you know, when they remove half the stomach and they remove a meter of gut, they suddenly discovered that people the day after the surgery was already having massive changes in their appetite. And that's how they discovered GLP-1, that actually what happened was a lot more food was reaching the lower gut, and suddenly people's appetite would literally change overnight. It also increases the release of insulin. It's an incretin, and so therefore it became then a main treatment for people with diabetes, type 2 diabetes. And then they discovered that they also lost dramatic weight. So then there was a study done, a semaglutide study in 2021, which was people with cardiovascular risk factors, but not yet diabetes. And interestingly enough, in the placebo group, they lost something like 1.5 kilograms over a year. That just shows you how well diet works. And in the treatment arm of the trial, there was a 15 kilograms loss of weight. But what GLP-1 does is it temporarily changes your need to feed while you are on it. It's monthly injections. It's very expensive. When you go off it, the effect goes away. The majority of people, when they go off GLP-1, will gain all of that weight, and they will gain it very quickly because your body's in shock about why you've lost so much weight. Oh my God, we must have just been through a famine. So there's a huge challenge because we've got lots of young people in their 20s, 30s, 40s, all clamoring to their GPs wanting the miracle weight loss drug. And of course, the drugs themselves have still side effects and adverse events. And does it really make sense for you to have lost weight for 2 or 3 years of your life and then you can't afford it anymore and go back? Where we're excited about this drug is as an option, if you can ever get to an affordable option, is imagine you've got your patients who's in their 50s or 60s, who's got their diabetes or their severe cardiovascular risk factors, they've got arthritis, they've got back pain. There's no ways you're going to actually now help them to dramatically lose weight. Being able to have Ozempic as part of their or one of these drugs as part of their long-term treatment might just be a thought for the future in terms of managing weight. For our resource-limited patients, the important thing is to identify, to not start giving lifestyle advice to every single person just because they've got an increased BMI. First, identify who's actually at risk, and we can use our risk calculators for that. If you are going to give advice, you want to give advice that focuses on improving health. Don't focus too much on the scales. You're just going to depress your patient. And one of the biggest conversations we can have with our patients, and with most of our patients are not aware of what fiber is, what kind of foods have fiber, and how to increase fiber intake in their life. We want to look if they can increase quality protein. That's more expensive and not always possible. And we want to be able to have a conversation about ultra-processed food. So it's interesting when you look at the traditional meals that people used to eat, so your sampan beans, for example, your traditional stews, a lot of the traditional rural diets was actually very high in fiber diets. And the challenge has been more the moving on to the ultra-processed foods. One of the tips when giving dietary advice is try and change one thing in every consultation. Never give your person a whole diet plan unless they're asking for it. But try and identify one major thing, whether it's out of specific ultra-processed food or a too much Twizzler, or I had a lovely diabetic the other day that whipped out a packet of jelly beans and asked me if these were okay. So being able to just identify the one thing that they can change. This is just a very quick little advocacy thing. So one of the things that they're talking about in Europe, there's a lot of massive pushback, so I don't think it's ever going to happen. But we like the idea that every single ultra-processed food should have a label on it that it is an ultra-processed food, and have on it how much salt and sugar and carbs and fiber is in that, and that there should be posters in every healthcare facility and a campaign around being people to be made aware for which people should not be having ultra-processed food. So if you've got diabetes or hypertension or high heart disease, interestingly, the recommendation is if you're under 12 years old or over 55, that you should be avoiding any food that is labeled as a UPF. It'll be an interesting research question as well. So let's actually now get to the medication part of the treatment, and I'm going to focus on the public sector guidelines and the latest guidelines from the EML, and I'm going